I'm going to talk today about, I'm going to try to focus on the research on psilocybin-assisted treatment for alcohol use disorder. My goal here is to give a little bit of a historical overview about why are we doing this? What's our justification? I'm going to talk about two studies actually. One is a pilot study, and one is the ongoing current phase 2 clinical trial of psilocybin-assisted treatment for alcohol use disorder. And then towards the end, I'm going to talk about a little bit of qualitative research that I did that actually pulls from data on the pilot study that looks a little bit more at patient experiences and how people experience this treatment, people who are actually going through it and experiencing changes in their drinking related to it. If I get through all of that in 20 minutes, we'll be in really good shape and I'll take some questions. And I really look forward to your input. But I'm also going to be around here the rest of the conference, rest of the weekend. So if there's something else that you're curious about, come and find me and we'll chat. So again, my name is Elizabeth Nielson. I'm from New York. I'm a psychologist. I'll go over a couple of my affiliations and things that I do in life. I work at NYU School of Medicine and part of the Experimental Therapeutics Research Laboratory under PI Michael Bogenschutz and Stephen Ross. Our funding there, the funding for my work there comes from Hoffer Research Institute, from USONA, from River Styx Foundation, as well as various other private donors throughout the years. I have been with that group since around 2014-15, so seen this trial through quite a lot. I'm also a therapist on the MAPS MDMA-assisted research program, working on the phase 3 trials for post-traumatic stress disorder, which is very exciting, back in New York. I'm the director of training and education at the Psychedelic Education and Continuing Care Program at the Center for Optimal Living in New York. That is a very big mouthful, but basically I help to design programs, continuing education programs for psychologists and other mental health professionals that want to learn about psychedelics and psychedelic research. And I'm a clinician and therapist at New York State Psychiatric Institute, which is part of Columbia University. It's an affiliated public research institute, one of the oldest in the nation. And there I'm working on the Compass Pathway-sponsored phase 2 trial of psilocybin for treatment-resistant depression, which you've probably heard about. I'm also a former NIH T32 grant recipient, so some of what I do is actually funded by our National Institutes of Health. That's over now, but still kind of feeding off work I did at that time. The research that I'm going to talk about today was funded through Hoffer with psilocybin from USONA. So many thanks to all those folks for helping this stuff get off the ground. Let's get started. Why psilocybin-assisted therapy for alcohol use disorder? Did that go? Mm-hmm. There we go. Oh, I know why, because it's not right. If there's like movement, it's not happening. So that might happen a few times. Let's go back to our history. I think you guys have probably all heard of Albert Hofmann, yes? Discovered the effects of LSD in 1943 and Sandoz started distributing LSD for mental health professionals to explore. I'm going to stand over here because that light is really bright. For mental health professionals to explore its use for two particular purposes. One was to see what it would be like for mental health professionals to have an experience that could be somewhat like psychosis. So this was back in the psychotomimetic theory. And also to as an adjunct to psychotherapy. And so in the 1950s in the United States and in Canada and most of Europe, if you were affiliated with a university, you could just write Sandoz a letter and say, here's my letterhead, I'm a researcher, I want to do some research, and they'd send you a whole bunch of LSD in the mail. It doesn't work like that anymore, but some of the people that were interested in working with LSD were based in Saskatchewan, in Canada, namely Abram Hoffer and Hoffer Osmond, who came from England. And the atmosphere in that place and time was very much one of exploration and innovation, especially in mental health. The government was really supportive of finding new and innovative solutions, and they were specifically interested in, this group was specifically interested in research with schizophrenia and alcoholism. And they began to do their exploration with LSD. They were working with it for schizophrenia, and they got the the bright idea, actually, I don't mean that sarcastically, a very bright idea to try using LSD for alcohol use disorder. And they started some really early research. Initially, they thought they could use LSD to give people like a delirium tremens-like experience, but before people got sick enough to actually have the DTs. It turned out that people were more inspired and motivated by the positive end of the experiences they had than terrified because of the horrible delirium tremens-like experiences they were having. But the research took off from there, and the idea of using LSD for alcoholism spread. We had a large program of research at Spring Grove, which is part of the Maryland State Psychiatric Institute. This was like the longest running LSD research program in the United States. Stan Groff was there, Bill Richards was there, various others. And their work, one of their primary focuses of their work was LSD for alcohol use disorder. And their work continued into the mid-70s, actually, long after the many other research programs got shut down just due to increasing restrictions and regulations. I know I'm skipping a lot here, but I'm going to go straight to sort of our modern era. You may be familiar with this paper published by Krebs and Johansson. This was from 2012. It was a meta-analysis where they went through and pulled all the studies they could find with data that was of the quality that could be pooled on the use of LSD for alcohol use disorder from the 1950s and 1960s. I think it was everything pre-1964. Because until then, there had been a lot of evidence, but everybody was it was sort of considered inconclusive, right? It wasn't enough participants in any one trial or strong enough results. They came up with 6 studies that had results that they could pool where there was a good enough, I'm gonna go back to this one, there was a good enough controlled conditions, those sorts of things. Most of these participants were males, inpatient units. Doses were single session doses of between 210 and 800 micrograms. That's pretty substantial. That doesn't give you the DTs, I don't know. Great variation in preparation and support, but the meta-analysis showed basically almost a 2-to-1 odds ratio in favor of the use of LSD for alcohol use. And the number needed to treat was about 6 to 7 for post-treatment follow-up. Now, number needed to treat it's not a phenomenally wonderful measure, but it does help us compare treatments. And well, I don't have that slide. Wait a minute. Oh, what did I do? Go back. Just by way of comparison, you'll see citations of some of the other approved treatments that we have for alcoholism, like naltrexone and acamprosate being somewhere around like number needed to treat of 9 or 10. The lower the number needed to treat, the better. So this is a pretty substantial improvement, right? It's sort of a signal that we should do some more work with this. So what are we actually doing? Well, now research has sort of switched over to using psilocybin instead of LSD, and there's a couple reasons for that. First of all, psilocybin scares people a lot less than LSD. It produces less anxiety, maybe less amphetamine-like side effects, less muscle tension, and those sorts of things. So it's a little bit easier for study participants to swallow that experience, to actually go through that experience, but we don't actually give people mushrooms. All of the psilocybin in our studies is synthetic. The initial batches were made by Dave Nichols, and then USONA's manufacturing after that. The other really great thing about LSD is that about psilocybin is that the experience is sort of wrapped up and done in about 6 hours, and we can have an 8-hour session, then we can go home at the end of the day. In the 1950s and 60s, we didn't have so much stringent oversight that we had to stay with people through, or the same people had to stay in the room or keep people there overnight. You could perhaps, have a therapy for part of the session and then allow the person to be monitored by someone else, a nurse, a study aide, or something like that. But the way that our studies are structured now, we have to have these 2 specially trained therapists in the room with the person for the entire duration of the session. Now, I don't know about you, but 12 hours is a really long time to be doing that. So psilocybin lets us sort of fit this into a day, and the strength of experience is certainly significant and affects more or less comparable. This pilot study, proof of concept study, was done at the University of New Mexico. Again, this was designed by Michael Bogenschutz as the PI. And the idea was just to demonstrate the feasibility of providing psilocybin-assisted treatment for alcohol use disorder. So single group design, 10 participants, 12 weeks of therapy, and it's actually with 2 psilocybin sessions. Again, this was open label, so everybody in this study got psilocybin. The outcomes are significantly very positive. I know Matt Johnson just threw this particular graphic up a couple of moments ago, but what I want to emphasize that was not highlighted on his slide, because I put the highlights in myself, was that pretty much all of the change points from baseline through all of the follow-up measures, like week 1 to 4 is pre-psilocybin dosing, right? So baseline to everything after the first psilocybin session, and then weeks 1 to 4 to everything following that, baseline to everything afterward, and weeks 1 to 4. The only one that isn't significant happens to be this weeks 1 to 4 versus weeks 9 to 12 for reduction in heavy drinking days, but not in overall drinking days. So this is measuring 2 things, reduction in percent drinking days and reduction in percent heavy drinking days, and this is cumulative. These groups aren't mutually exclusive. So this looks really good, and I'm going to give you some quotes in just a moment about how people describe their experience of this, but very, very promising. Certainly not a comparison study. This had no control group, but 2 kinds of therapy, motivational enhancement and taking action, or meta therapy, and then that's more of a motivational interviewing style, cognitive behavioral skills-based therapy. And then preparation, support, and integration is really about preparing people for the psilocybin session, talking to them about their expectations, how to manage their states during the session, what the therapists are going to do to assist them and help them and keep them safe, and all of that. Psychoeducation, rehearsal, inquiry about key themes afterward. So there's 2 therapists, and each one of us is trained in following one of these tracks of therapy, but we do all the sessions together, and most of us are cross-trained, so there's a lot of overlap. I know I'm going fast here, but I'm going to skip photos of the room. The results from this study justified a double-blind trial, which is going on right now. The objectives are to characterize the acute effects of oral psilocybin between 25 and 40 milligrams per 70 kilos in alcohol-dependent patients. Again, this is DSM-4 criteria for alcohol dependence. Relative to diphenhydramine control, Benadryl is the placebo in this case. And everybody, let me show you this. This is good. So main study design. Again, you've got the 12 weeks of 12 weeks of psychotherapy ends about here, and then with the 2 psilocybin sessions. And then we've got about a 6-month follow-up period, and then people come back for what's called the extension phase, or the 3rd med session, which is an open-label psilocybin session. So everybody in this study does get a full-dose psilocybin session. Even though in the first phase of the study, that first 12 weeks, they may get either 2 psilocybin sessions or 2 diphenhydramine sessions, they're definitely getting a psilocybin session when they come back for that 3rd session, which everybody can do as long as they're sort of in good standing with the study and there's no medical counterindication or reason not to at that point. Obviously, we reevaluate a little bit, but there's some ancillary studies going on that I'm not going to tell you too much about for the sake of time, but we are doing pre and post fMRI scans on surrounding that first session. So people who opt to be in the fMRI can get scanned for which we can then compare to the main study results. And there's also a qualitative interview study going on, which I'm working on currently at this time, which is giving people who have had their 3rd psilocybin session a chance to come in and talk even more about their experience, what it's like, what it means to them, and how they see it unfolding in their life. So in order to look at some data from this study is ongoing right now, but and I think recruitment's probably going to be wrapped up over the winter. It'll then take another year for all of the data to come in and then all of the data to be analyzed, so don't even look for publications until like 2023. You know how those reviewers and revisions go. But we did want to take a little bit of a look at what some of the signals might be thus far. So the team decided, and this is mostly Michael Bogenschutz and Sarah Menenga, who's a postdoc and does a lot of our work there on the data, that what we would do is look at the first 56 participants who have completed that 12-week session, who have either had 2 diphenhydramine or 2 psilocybin sessions. And since we give everybody the mystical experience questionnaire, everybody familiar with the MEQ, the mystical experience questionnaire? Yeah, it's like part of the furniture of the psychedelic research world. Like you can't, I mean, it's used in almost every study. It has been widely criticized, I fully acknowledge that, but it is being used to determine the strength and nature of mystical experience, and there is reason, both theoretically and in terms of data we've already seen, to suspect that the strength of mystical experience is correlated with positive outcomes, and that's true for addiction studies, but also for depression studies and other kinds of clinical studies. We'll leave it at that for now. What we did was, instead of unblinding the groups, because we can't unblind the groups yet, it's not that time yet, we took those first 56 participants and split them into 2 groups based on high mystical experience score and low mystical experience score. Just split it right down at the median. And we wound up with, so it's 56 participants, that's 28 participants in each group. And of all these participants, 32 male, 24 female. We're going to take a look at some of the outcomes and see what we might see so far. So we looked at percent heavy drinking days and drinks per heavy drinking day. These are the same kinds of measures that I showed you on that graph that was the first outcomes from the pilot study, right? And interestingly, and this probably will get like smoothed out when all of the data is, but there was already a difference in the 2 groups at baseline for percent heavy drinking days, and this is just some sort of artifact of randomization. Again, the full sample isn't here. This is only 56 people. I suspect that when we have the full sample, this difference will even out. But this difference was maintained. This is significant at 0.05, and it's maintained at week 12. So we're not going in the wrong direction. We can say that at least. And then in terms of drinks per drinking day, again, we're seeing a trend towards fewer drinks per heavy drinking day, and in the higher MEQ score group, but it's not significant at this time, so it's not significant yet. It may become later when we have either a longer term follow-up, because don't forget, we're going like another 6 months, we're going like all the way over there, or when we have more participants to really fulfill these larger numbers in these groups, okay? Just as a side note, drinks per heavy drinking day is in this study is defined as 4 or more drinks on one day for female participants and 5 or more drinks per day for male participants. Yes, I know that is a horribly binary way to split things, but that's what that's the way it's written, and that's the way our health system defines heavy drinking days. So these are sort of standard definitions that we're working with. Okay, let's go to the next one here. Well, that's it. Again, we're doing also in this study, we're collecting information on depression and anxiety. These are not people who meet criteria for clinical depression or anxiety, but we are seeing, again, we don't have significant differences, but we are seeing trends in lower scores on depression and on anxiety amongst the higher mystical experience score questionnaire groups. This is my favorite. We're looking at alcohol craving, and we're seeing a difference with the higher mystical experience score questionnaire. Again, this is week 5, so this is a measure of craving that's taken 1 week after the first psilocybin session, and then this is at week 12, so this is this is 4 weeks after the second psilocybin session. And in both of these, we're seeing a significant difference already with 56 people in significantly lower craving in people who had a higher mystical experience score questionnaire. So higher mystical experience score on that questionnaire. So the reason that I particularly like this is because this to me reflects what I'm seeing as a clinician, as a study therapist in my participants. They're coming in and saying, not only am I not drinking, I don't feel like it. I don't want to, I'm not having that pull. I know, they'll say things like, I knew I could do this before, I've done it before, I've made it 12 weeks or 10 weeks or whatever without drinking, but this feels really different. All right, I don't have that pull anymore. Yeah, we're getting there. So yeah, we really are. This is like the last section, then we're going to go to some questions. So my interest as a clinician really is in the patient experiences and less than the numbers. So how do people actually experience this kind of treatment and how do they reflect on it? So in order to take a look at that, I did a qualitative content analysis. I looked at 17 debriefing sessions, which are the sessions that are done the morning after a psilocybin experience or psilocybin session from that first pilot study that we looked at before. And I looked at a range of different constructs that theoretically we think are related to change, as well as sort of scanned the transcripts to see if anything else cropped up. So we wound up looking at how people describe mystical experiences, how they describe ego dissolution, how they describe both motivation and commitment to change, which are really written into the protocol in that meta or MET therapy track that we're doing, that motivational track. We looked also at dysphoric experiences and their resolution in therapy, and we looked at stigma. I'm particularly interested in the barriers to treatment for substance use in general. And those of you who are familiar with substance use literature already know that stigma is a huge barrier to getting good, empirically supported, evidence-based treatment for substance use disorder, and even to the uptake of empirically supported treatments in the substance use treatment world. So we looked at stigma and how people were experiencing how people were experiencing this treatment, if they were experiencing stigma about it, if they were sort of afraid to tell people about it, or experiencing negative consequences from telling people about it. I'm not going to read a whole bunch of quotes, but I have two that I want to share with you. Again, these are published in an article in Frontiers from 2018. So dysphoric experiences, this is one study participant during her, speaking of her first session, saying yesterday was devastating, but it was the kind of devastating that I could wake up from knowing and feeling everything as though it has happened, but I still have everything. It happened like it was supposed to happen. If I was uncomfortable, I deserved it. That's how I looked at it. I was always aware of what was going on, and I need to take full advantage of it, as gut-wrenching as it was. So this is somebody who's really describing that perspective of it's dysphoric and it's difficult, but it's also useful. And a lot of our psychotherapy portion is really about preparing people to hold that dialectic of the difficult may also be the useful. And I think she expressed this beautifully. Stigma and isolation, this quote particularly struck me. My sister's the only one that knows that I've kind of gone through this, meaning this treatment. And I've told one friend a little bit, and I don't know that I'm actually going to openly express this. I don't know if I'm ready to. I don't know that anyone could understand it. I'm not ready to talk a whole lot about it to others. So in this particular case, we have somebody who's feeling that isolation, perhaps that stigma, perhaps some extra caution around sharing this with people. And I think this is one of the cases where maybe as we treat more people and there becomes a larger pool of public people that have gone through this treatment, people have more opportunity to connect with each other. But certainly that initial support of the therapist is especially important when someone feels they have no one else they can really talk to about it. Couple of conclusions. Why do we think this might work? Well, there's the mystical experience theory that is central to the AA model, that the mystical experience helps people, motivate people to change. Certainly that is partly borne out by the MEQ scores. There are psychological factors, self-efficacy, insight, motivation, acceptance, compassion, new perspectives, all of that stuff. And we've got physiological mechanisms too. Those of you who are interested in receptor modulation and neuroplasticity, those are also functioning simultaneously. I want to give a really big thanks to, first of all, everybody here that invited me and got me here and helped make this possible. Thanks to all of you for showing up. Awesome. Yes, round of applause. My whole team at NYU for amazing work. And one more is all of the supporters of this research, the funders, the donors, the people that provided the psilocybin, and the participants who provided their time and let us work this stuff out with them. Thanks so much.
Another fascinating speed presentation, since it's lunchtime and we're not only hungry for physical stuff but also for knowledge. We have 10 minutes now for discussion.
Great.
So the first one.
I was wondering, I have two questions, but I was wondering, when do people get their last, or have their last drink, and how much time is between that and the sessions? Is there a withdrawal period? Do they go to detox?
Sure. So this study doesn't include people that would need like inpatient detox. It's for people that can are deemed to be safe to stop drinking on their own without additional pharmacological treatment or medical monitoring, and they are assessed for that when they come into the study. People are asked to try to stop drinking 1 week before the first psilocybin session. Many do, I would say probably the majority. They're really required to not drink at least 24 hours before the first psilocybin session. That's so that there's really no chance of them actually having a hangover or withdrawal on that day. And some people stop earlier than that. Some people, because the therapy starts about 3 or 4 weeks before that first psilocybin session, some people stop right then. They're already motivated, they want to take a longer break, they're ready to go, and they stop. Yeah.
So it seems like a lot of the results are dependent on their mystical experience, sort of predisposition. So is there any kind of genetic testing for these patients to see if they have any certain polymorphisms that might be able to sort of see if they're more prone to placebo or not, and which kind of person it would be helpful for?
That is a great question. You know, my sense is that the mystical experience score is going to be correlated with the results, at least in large part, but it's not going to tell the whole story. There are going to be other explanatory factors and other covariates and things. There is some of that data collected. I don't know what the status as far as its evaluation is going to be. So I do know that there is some data, I think, being collected. But what the actual measures are and how it's going to be looked at, I'm not sure.
Would these be mostly functional alcoholics that are in the study versus?
These are people who, well, they're stable enough to be able to come to the study and do all the study visits and to be able to stop drinking without pharmacological intervention or inpatient and stuff like that. Yeah. So, and the fMRI will tell us more, I think, about specific neural correlates as well. Yeah. Okay, thanks.
Hi.
Hi.
I love that you mentioned that mystical experience is a part of AA, and I actually
Yes.
think AA denies its own psychedelic roots and build-up use belladonna treatments, and then his desire to ship LSD around people once he tried that. But I'm curious if you think that the way that this, like, people are drinking less, having fewer drinking days, problematizes like the sort of 12-step perspective on alcoholism. That like once you're an alcoholic, you have to be sober forever, and that's the end, right? Like that's the ultimate goal. But if people are drinking less, like do you see people sort of like return or like enter a phase of normal drinking or more normalized drinking relationship to alcohol? Does this change that paradigm in any way?
I mean, the way that the study is designed, it's designed to capture and measure significant reductions and changes in drinking, be they complete abstinence or no more heavy drinking days, but only moderate drinking days, or reduction in overall number of drinking days. So it's designed to not be exclusively like, you're either completely abstinent or you're not. We know from the general world of addiction treatment that lots of people fall into a category of being able to make other changes to their drinking, reductions in drinking. So I think this study is nicely set up to be able to capture that. And if you're asking, like, does it validate that as a potential outcome? Sure. I mean, I think, a substantial reduction in someone's harmful behavior, if that's what they want to make, is very promising. It doesn't preclude abstinence at another point, but it could be a step in the right direction for someone. Yeah.
So myself on it first, maybe. Showing positive result in that in alcohol misuse would be major. We all know it, but I wonder about the population. Have you looked at verbalization, abilities, at intelligence, at drinking years, and maybe following brain damage?
We're not doing intelligence testing and that sort of thing, like a WAIS or anything. We do take a very complete drinking history, but the way that the drinking is measured in the study, we're looking at current alcohol use and meeting the diagnostic criterion currently. So it may be sort of a follow-up data analysis question to ask, like, do people who have a longer drinking history prior to that respond differently than people who have a shorter drinking history? But the way the study is designed, it's working specifically with people who have a current meet criterion currently, right?
1, 2.
What's the rationale for using 2 sessions of psilocybin, and what kind of therapy have you been?
So the psilocybin sessions, I think one, for people for whom it's their first experience, that first one can be a lot about just like getting there and going through it the first time, sort of taking that initial plunge. And having a second session gives people an opportunity to, first of all, take the pressure off of that first session. So it's like they don't have to completely get to everything in that first session. It also gives us a chance to adjust the dose, because we've written into the protocol, we can increase the dose after the first session depending on how the first session was tolerated. And Michael Bogenschutz and others have written many times that they do think that people who have addictive disorders, especially alcoholism, may require higher doses than other particular disorders, just because of the way that psilocybin is interacting with the receptors, which have been changed over the course of the addictive pattern. So being able to have that first session, if we have somebody who really doesn't have a very strong response, we then have a chance to go back and increase the dose. All the dosing in this study is weight dependent, and each capsule is compounded for that person about a week before their session. So we can adjust it that way. It's another really good reason. Change also takes time. I mean, we want to keep people in the study and sustained over that period of time, so that by the time they hit this 12-week mark, they've really had 12 weeks of therapy. Now, the therapy is 2 kinds of therapy. The motivational interviewing style, cognitive behavioral style therapy really is based in empirically supported treatments like motivational enhancement therapy, and does some cognitive exercises and then some real skills building around that. So everybody in this study is getting really good evidence-based treatment with the addition of the psilocybin or not.
I assume everybody participating in the study knew that it's about the alcohol abuse, isn't it?
Absolutely,
Do you
yes.
have any data or have you heard of anything where it was not in their consciousness that this is about alcohol, but they entered a similar treatment for whatever reason, trauma or experience?
I'm not quite sure I understand that somebody came into this study thinking it was about something else?
No. Do you know of any data where alcoholics got the treatment without knowing that this is to treat their alcoholism?
Got psilocybin?
Yes.
Well, if it was psilocybin to treat their alcoholism, they would probably be aware of that. And
No, they could. They could enter a study because of many reasons.
oh, and then change their drinking?
Yeah. Is there any data about this? Because you said some people stopped before they even took the
Right,
drug, so
right.
that means they have
The only thing that I can think of, and if you see Ingmar Gorman floating around here, you can ask him more, but he's presented some data on reductions in drinking in the MDMA trial, where people were going in for trauma treatment and getting MDMA and actually made positive changes to their drinking.
I was looking for a similar thing.
So that's what comes to my mind off the top of my head. It may have been noticed in other studies as well. I don't know.
Last question.
Great idea.
Oh, now four hands.
Oh no.
So maybe somebody could ask before, maybe you? You?
What's the screening procedure and the exclusion criteria for this?
So people usually start with a screening phone call. It just goes over some really basic eligibility criterion and ensures that they know, that it's an on-site study. They have to actually come into Bellevue Hospital. Sometimes we get calls from people who are like, I'm in Hawaii. That's nice, but they have to be able to come into the hospital. So we go over some basic things like that. Then they come in and they have it's like a 3 or 4 hour appointment. It's like a full medical screening, psychiatric screening, lots and lots of questionnaires and tests and measures and things to make sure that they meet all of the inclusion and exclusion criteria. And then if they, and there's lab work done, EKG, all of that. And then if that all the results from that come back and everything pans out, then they're considered eligible, they get a call, they come back in and they do another few hours of assessments, which is like the baseline, and then they start the therapy.